Hi, everyone. Um, this lecture, we're going to talk about infectious disease of the heart. I'm going to save the case studies for in class, and we're just going to get the content down so that we can do some interactive things in class. So I'm going to share my screen, and then I have to pull up my PowerPoint. All right, so like I said, cardiovascular disease, infectious disease of the heart. Um, Infectious disease of the heart means that it's an infection that affects any of the heart's three layers. And those types of things are infective endocarditis, myocarditis, and pericarditis. Infective endocarditis affects the endocardium, myocarditis affects the myocardium, and pericarditis affects the pericardium. Rheumatic endocarditis is a very unique infective endocarditis syndrome that we're going to cover briefly. So, rheumatic endocarditis. Acute rheumatic fever is an inflammatory disease that can develop following a throat infection with group A beta hemolytic streptococcus. The demographics for this are commonly school-age children. The trigger for pathogenesis develops after an episode of the streptococcal pharyngitis. Complications can lead to um, rheumatic heart disease. The clinical manifestations of rheumatic heart disease, the symptoms are a new heart murmur, cardiomegaly, pericarditis, and heart failure. Long-term issues with rheumatic heart disease may lead to mitral valve stenosis or regurgitation, which can persist into adulthood. And lucky for you, there's a few more lectures that cover what those are. Prevention is key for this. So, how do we prevent this? Prompt treatment with effective treatment of strep throat with antibiotics is crucial to prevent the development of acute rheumatic fever. It's very important that we treat strep throat for a number of reasons, but this is really why. And then transmission. We want to stop the spread of streptococcus. Streptococcus is transmitted through direct contact with oral respiratory secretions. The risk factors for this disease is malnutrition, overcrowding, poor hygiene, and lower socioeconomic status. So think like if you're into history, think like when we used to have what they called the ghettos of the in like New York City, it would be certain cultural populations that would stick together in like apartment buildings and things like that, and it would be very overcrowded. Things like that, but that was like a long time ago. Epidemiology for rheumatic endocarditis here is the incidence of this disease. It really has decreased as we develop countries and is now primarily seen in developing nations. Um, Now we move on to infectious endocarditis. Endocarditis usually develops in older adults or in people with prosthetic heart valves or cardiac devices. Staphylococcal endocarditis infections of the valves are in the right side of the heart are common among adults who use illicit IV drugs. Hospital-acquired infective endocarditis occurs most often in patients with debilitating disease or indwelling catheters, and in patients who are receiving hemodialysis or prolonged IV fluid or antibiotic therapy. The mortality rate is 14 to 22% during hospital stay and up to 40% within a year of diagnosis. So, the pathophysiology is that a deformity or injury to the endocardium leads to a clot formation. The clot formation is really the fibrin and platelets that aggregate right on that valve. Um, to cause vegetation. The infectious organism invades that clot, resulting in vegetation in the endocardium. The vegetations can embolize and spread through the body, and then continuous clot expansion conceals the infecting organism, complicating defense mechanisms. And then the infection erodes the underlying structures, damaging valves and causing abscesses. The risk factors for infectious endocarditis are prosthetic cardiac valves and material for valve repair, implanted devices. When you think of an implanted device, think of like a pacemaker. Um, History of bacterial endocarditis. So if you have had bacterial endocarditis, you are at greater risk of getting it again. Congenital heart disease. So things like unrepaired cyanotic disease or repaired prosthetic material within 6 months. So valve replacements are at risk for this within 6 months. Cardiac transplant with valvopathy, IV drug abuse, body piercing, branding, and tattooing, and then hemodialysis. Clinical manifestations are insidious onset. Primary symptoms include fever and heart murmur. Fever may be intermittent or absent, particularly in immunocompromised patients. You're going to look for those petechiae clusters, those Osler nodes, painful nodules, the Janeway lesions, painless macules, Roth spots, hemorrhages in the eye, and the splinter hemorrhages under the nails. So now we talk about complications. Systemic embolization is a complication commonly affecting the CNS, and then heart failure is the most frequent complication, which may need surgery. For assessment and diagnosis, the signs can mimic other disease process, so other things that are cardiac related. And then we get a definitive diagnosis by I um microorganism identification in separate blood cultures and evidence of vegetations via the echocardiogram. Blood cultures should be taken before antibiotics are administered because um, it's very important to understand the what the microorganism is, and if you take it after you administer the antibiotics, then you run the risk of creating a negative culture. But it's important to remember that negative cultures do not rule out infection. You have to look at the whole picture. All right, so then we move on to prevention. Prevention is key for this. So it's very important that we give that antibiotic prophylaxis for high risk patients before certain procedures. Dental work. Dental work is the biggest reason for this endocarditis, aside from IV drug use. So dental work. So that is likely to be a question somewhere, whether it be the NCLEX or the unit exam, that for endocarditis, think dental work. Recommendations for good oral hygiene to prevent that bacteremia. And then patients with IV catheters require meticulous hygiene and aseptic techniques. So remember, when you have a patient that you're treating who does not have any other issues um, with endocarditis, but they have an IV catheter, that puts them at risk for endocarditis. So that's why we keep those IVs clean. Medical management. So, treatment focuses on eradicating the infection with appropriate antibiotics. We're going to do an IV for 2 to 6 weeks. We want to monitor through serum levels and blood cultures to ensure effectiveness. Um, and patients often require psychosocial support during treatment because it's a long road. Sometimes we get into surgical management. So, if we need surgical intervention if we have heart failure that develops. So we might have intracardiac abscess or recurrent systemic embolizations that also would require surgical intervention. Um, Sometimes the infection is unresponsive to medication, so we might have to do that valvular repair and replacement. Surgical valve replacement significantly improves prognosis in severe cases. Repeat valve replacement is often required for prosthetic valve endocarditis. So if the prosthetic valve caused the endocarditis, we might have to keep replacing those valves. We want to make sure that we debride any vegetations and abscesses and close any fistulas. So, for nursing management, we want to monitor the patient's temperature regularly, observe fever course to evaluate treatment effectiveness. If that fever is coming down, then we're doing the right thing. We want to assess heart sounds to note any new or worsening murmurs indicating possible complications. We want to monitor for signs of systemic embolization and organ damage, such as stroke or heart failure. We want to assess for invasive we want to assess invasive lines for signs of infection as part of infection management. And then we move to plan. We want to schedule regular temperature checks and assessments. We want to plan rest periods to manage fatigue and promote patient comfort. We want to implement strategies for infection control practices such as hand hygiene and prepare the patient for long term antimicrobial therapy management post surgery. Our interventions for infectious endocarditis would be that we administer prescribed antibiotics, antifungals, or antivirals, ensuring adherence to medication schedules. We can use NSAIDs to alleviate fever discomfort and provide additional comfort measures. Some comfort measures that we would like to give are those light linens, air exposure, cooling methods, because remember, we have night sweats with endocarditis. And then we want to provide post-operative care and instructions to the patient. And for education, we want to educate patients and families on medication adherence, activity restrictions, and recognition of infection signs. We want to instruct on proper hand hygiene and infection and inform about the role of home health nurses in supervising IV therapy and providing health promotion and emotional support during prolonged treatment. That was a lot. So now we're going to move on myocarditis. And we want to note if you're using my concept map theory, you want to note the differences here and give those a good highlight. Because a lot of the things we have inflammation of the cardiac muscle, right? So the different layers are going to have different treatments. So you want to identify those things. Myocarditis is the inflammation in the myocardium leading to complications such as heart dilation, mural thrombi, and degeneration of muscle fibers. The mortality for myocarditis varies based on the symptom severity. Mild cases often recover while my they I'll start over. The mild cases often recover while others may develop cardiomyopathy or heart failure. And we'll get into cardiomyopathy in another lecture. Pathophysiology for myocarditis is we could have the causes are related to infectious agents that could be viral. And examples of that are the Coxsackie viruses, HIV, influenza. They can be bacterial, fungal, parasitic, protozoal, and spirochetal. They can also be immune related, so post infections or autoimmune disorders, and then toxic reactions, inflammatory responses to certain drugs. The inflammation can start in a localized area and spread, affecting collagen and elastin, leading to hemodynamic instability. The clinical manifestations for this disease process is that the symptoms can range from asymptomatic to severe. Um, Fatigue, tachycardia, dyspnea, syncope, palpitations, chest discomfort or pain, all the way to sudden cardiac arrest and acute heart failure. Assessment and diagnostic findings. Our initial assessments may show no or abnormalities. However, patients may exhibit tachycardia or chest pain. We're going to use our diagnostic tools. We're going to take an endomyocardial biopsy for a definitive diagnosis. we're probably going to get a cardiac MRI. It's a non invasive diagnostic tool that often will help us find the biopsy location. We are going to look for signs of structural abnormalities that may include cardiac enlargement and heart sound changes. And then for lab tests, we're going to grab CBC to see if that white count is elevated, a CRP for inflammation, a leukocyte count, and a SED rate. And then our medical management. So our treatment focuses on the underlying cause, like a lot of things. I come from emergency medicine, and that's what we do. We treat the underlying cause. So we would want to give antibiotics for bacterial infections or certain antivirals if it's viral, things like that. So medications. Patients should be on bed rest to minimize their cardiac workload and damage. We want to limit that physical activity, particularly um, in young patients until heart function normalizes. We want to manage the heart failure or arrhythmia following standard protocols, like whatever the heart failure or arrhythmia indicates. That's how we want to treat. This is what I was talking about highlighting. NSAIDs are not recommended due to potential for increased cardiac injury. So endocarditis, we can use NSAIDs. Myocarditis, we cannot use NSAIDs. So nursing management, you'll see consistently through these lectures that I do API. For assessment, we want to monitor for resolution of tachycardia, fever, and other clinical symptoms. We want to focus on signs of heart failure and arrhythmias. We want to do continuous monitoring for arrhythmias. That's super crucial. For plan, we want to establish a monitoring schedule for vital signs and symptoms. We want to prepare for potential interventions related to arrhythmias or heart failure. For intervention, we want to implement continuous cardiac monitoring for early detection of arrhythmias because arrhythmias are really going to do us in. We want to monitor patients for signs of digitalis toxicity. So if we're giving digoxin, we want to monitor for that. We want to notify the primary provider immediately if we do have that digitalis toxicity. We want to implement anti-embolism measures, so we might use compression stockings, passive and active exercises to prevent more thrombi, particularly in patients on bed rest. And then we want to educate patients and families about the importance of reporting any new symptoms, including changes in heart rhythm or signs of toxicity, and instruct on the significance of the anti-embolism measures and encourage participation in exercises as tolerated. Now we're moving into pericarditis. Pericarditis is the inflammation of the pericardium, the membranous sac around the heart. This accounts for 5% of emergency room visits for chest pain. The classification in etiology, so we classify pericarditis as acute, chronic, or recurrent. The etiology is either infectious or non-infectious. So the pathophysiology is we have an inflammatory process that may lead to a pericardial effusion, which is the accumulation of fluid in the pericardial sac, cardiac tamponade, which is that increased pressure on the heart. So if you have that sac that fills with fluid, so think like a balloon around um like a double-walled balloon, okay? So you have one balloon inside the other. You have the outer balloon is just a fixed size, but the inner balloon can get bigger and smaller by contracting, right? So if the fixed size balloon, the outer balloon, starts to shrink and gets like fills with pressure, right? Then the contraction just can't happen. That's cardiac tamponade. And then we can have constrictive pericarditis, which is a thickening and decreased elasticity of the pericardium, where it restricts that heart filling because it still can't pump. So the sac, any issue to the sac will cause the heart to not be able to pump. And then we could also have possible calcification of the pericardium affecting ventricular filling and cardiac output. So what happens when the heart can't pump? We can't get oxygen to the vital organs and the brain. So clinical manifestations here are, again, this patient may be asymptomatic. They can have chest pain. You can listen for that friction rub. They might have a mild fever, increased white count, anemia, elevated ESR, CRP, a non-productive cough, hiccups, dyspnea, and signs of heart failure. What are some causes of pericarditis? So we have idiopathic, non-specific. That would be the infection. So viral is most common. So think enteroviruses, herpes, adenoviruses. Bacteria is rare, but it comes with Mycobacterium tuberculosis. Fungal, again, rare, but histoplasma. And then parasitic, rare, toxoplasma. This can also be caused by autoimmune disorders like lupus and rheumatoid arthritis. Could be drug reactions where we have that immune mediated response. Could be related to adjacent structure disorder. So, like maybe an MI is causing the pericardium to be inflamed, or even pneumonia. And then we have neoplastic disease, so like metastasis or some neoplasms. Trauma, so chest injury or surgeries, and then metabolic, uremia or anorexia. So for pericarditis, the assessment and diagnostic findings are history, signs, and symptoms. That's how we're going to diagnose this. We can see it on an echocardiogram, so it will detect the inflammation, effusion, or tamponade. We'll see it on imaging, so CT or MRI, and then EKG. An EKG may show concave ST elevations and depressed PR segments. How do we medically manage these patients? So the objectives are to determine the cause, treat the symptoms, monitor for cardiac tamponade because we do not want cardiac tamponade. We're going to give things like analgesics and NSAIDs. So again, we can give NSAIDs for pericarditis and endocarditis, cannot give NSAIDs for myocarditis. We're going to give the analgesics and NSAIDs for pain relief. We're going to give corticosteroids if the NSAIDs are contraindicated. So there would be another reason why we can't give NSAIDs, but we can give corticosteroids. And then colchicine for severe cases. We can do procedures. We can do a pericardiocentesis, which is where we insert a needle into the pericardial sac and remove fluid for diagnostics or even symptom relief. We can create a pericardial window, which allows for that continuous drainage of that fluid. Or we can do a pericardectomy, which is surgical removal for constrictive pericarditis. When would we do a pericardiectomy? That's when we have that calcification. We want to remove that. Or if we have the thickening of the wall, we might want to remove some of the piece so that they can allow the heart to pump the way that it should. So nursing management, again, we have that API. We want to evaluate the patient's pain level and characteristics, monitor for signs of cardiac tamponade, which cardiac tamponade symptoms are hypotension, tachycardia, and JVD. We want to assess for symptoms of heart failure. We want to develop a plan for pain management tailored to the patient's needs, establish guidelines for activity restrictions based on the patient's condition, set goals for monitoring vital signs and symptoms related to cardiac function. Then we want to provide analgesics and psychological support to maintain pain and anxiety, encourage position that alleviates discomfort, such as forward leaning or sitting. We want to implement activity restrictions and gradually increase activity as the patient's condition improves. We want to regularly monitor vital signs and perform assessments to detect early signs of complications. And as far as education goes, we want to educate the patient and family about the importance of a healthy lifestyle to boost immune function. We want to discuss the signs and symptoms of cardiac tamponade and heart failure, emphasizing the need for prompt reporting, and provide information on the management of pericarditis and the importance of follow-up care. Pericardial effusion and cardiac tamponade. Pericardial effusion is the accumulation of fluid in the pericardial sac. Cardiac tamponade is a condition where increased pericardial fluid pressure compresses the heart, leading to reduced cardiac output and obstructive shock. The causes of these things are advanced heart failure, pericarditis, metastatic carcinoma, cardiac surgery, and trauma. So, pathophysiology, right? Uh, Normal pericardial fluid in that sac is 20 mLs. So, we use that fluid to reduce the friction of the heart. And we talked about that a little bit when I reviewed the anatomy and physiology. So, the pathophysiology of these things are increased fluid raises the pressure in the pericardial sac. So, like I talked about, with that elevated pressure, it's going to cause elevated pressure in all cardiac chambers. And then it's going to decrease that venous return because that arterial compression is pressure backflows. So we can't get the blood to the heart because that pressure is so high. So we're not filling the ventricle. So we're not pumping the blood out. It's just like a backup. I like to think about cardiac as plumbing. So think if that helps you, try that. Symptom development is going to be the slow accumulation. Symptoms may not appear until 1 to 2 liters of fluid accumulates. It's a lot of fluid. And then if it rapidly accumulates, we're going to have sudden issues such as hemorrhage, and we can lead to acute symptoms. The clinical manifestations are acute cardiac tamponade is sudden chest pain, tachypnea, dyspnea, JVD, hypotension, distant heart sounds. Can't hear the heart pumping because there's too much fluid. It's like underwater. We could have a subacute presentation with, like, we start to feel that chest discomfort, fullness, gradual development of dyspnea, JVD, hypotension, tachycardia due to low cardiac output. And then we might have this pulsus paradoxus. This is a key term. Know what pulsus paradoxus is. It's a systolic blood pressure drop by at least 10 millimeters of mercury during inhalation. Trust me, know that. Assessment and diagnostics. So, echocardiogram. This will confirm diagnosis and quantify the pericardial fluid. We have a chest x ray, which is going to show that enlarged cardiac silhouette. And then an EKG typically shows tachycardia and may exhibit low voltage. Medical management. So, the acute management is pericardiocentesis. We're going to aspirate that pericardial fluid if cardiac function is impaired. We're going to do continuous ECG monitoring and vital signs during this procedure. And then a possible placement of a catheter for ongoing drainage if there's a significant fluid that needs to be removed. And then these patients run the risk of recurrent effusion. So if they have recurrent effusions, we might think of this pericardiotomy, surgical procedure to excise part of the pericardium, allowing drainage of the lymphatic system. This is definitely going to be conducted under general anesthesia. And then, as with any procedure, we have complications, and these are things that you want to either you're going to monitor for post-op, but you also want to educate your patient on. And this is the things that you talk about in informed consent. So we might have coronary artery puncture, we might have myocardial trauma, we might have an arrhythmia, a pleural laceration, and a gastric puncture. So API again for nursing management, we want to monitor that heart rhythm, check blood pressure regularly, assess venous pressure because we're looking for that JVD, evaluate heart sounds for muffling or changes, perform echocardiograms as needed to quantify fluid. We want to develop a monitoring schedule for vital signs, establish criteria for when to repeat diagnostic tests, set up a patient education regarding symptoms of worsening condition, plan for potential interventions like pericardiocentesis or pericardiotomy if indicated. We want to administer treatments as ordered, so maybe some diuretics if applicable. We want to perform a pericardiocentesis if cardiac function is compromised. We want to provide supportive care, including oxygen therapy if needed, ensure continuous monitoring of vital signs and symptoms post procedure. And then we want to teach our patients to recognize symptoms of cardiac tamponade, such as that chest pain or dyspnea, instruct on the importance of reporting any new or worsening symptoms immediately, provide information on the purpose and process of procedures like pericardiocentesis, and discuss lifestyle modifications and follow up appointments to ensure ongoing management. And that is it for this lecture. There will be quite a few more lectures coming, but I wanted to break it down so that you were able to bite these off in small chunks, okay? So I look forward to seeing you in the next video.